Assalamualaikum students, welcome back to my YouTube channel. Please subscribe my channel and hit the bell icon. Okay, today's topic of discussion is peptic ulcer disease. Now, peptic ulcer disease is a very common disease in Pakistan. Many patients you will see a lot of patients in the wards of peptic ulcer disease. So let's just start. Now, number one is the thing that what is the cause of what is the pathophysiology of peptic ulcer disease. There is actually an imbalance. It is actually an imbalance between the mucosal defenses and the damaging forces, which means that mucosal defenses, there are a lot of factors. For example, prostaglandin release that increase the blood flow. There are bicarbonates. There are other several factors that are responsible for protection of the lining of the stomach. There is mucosa, number one, that is responsible for protection against the acid and all the factors. Similarly, there are damaging forces that we will discuss later. There is a marked imbalance between these two factors leading to the disease. Now, it is a very simple topic. You should be knowing the basic concept and pathophysiology. This is what all about it is. Now come to the associations that are. Number one is the NSAIDs use, that is non-steroidal anti-inflammatory drugs. Those patients who are taking NSAIDs, mostly patients comes with the complaints of joints. They have joint pain, etc., and they are having rheumatoid arthritis or other diseases of the bone, and they are taking NSAIDs. For a longer period of time they are taking NSAIDs, and it will result in imbalance between these two factors and lead to the peptic ulcer disease. So whenever comes a patient, you should ask about the history of NSAIDs. Second most common reason is the H. pylori, that is a gram-negative bacteria. So these are the most common diseases factors that are responsible for this disease. Now, location is the gastric antrum, and the duodenum is the most common location. Although peptic ulcer disease can occur in the esophagus as well, is actually just a ulcer formation responsible for it, but the most common locations are gastric antrum and duodenum. Now come to the pathophysiology of the disease. What happens is actually if there is H. pylori infection, it will lead to the production of as H. pylori contains urease enzyme, and it will degrade the urea into ammonia and carbon dioxide. So ammonia is alkaline in nature, and it will cause hypoacidity and will lead to the damage of the mucosal lining. So this will lead to the peptic ulcer formation. As acid will come, the damaged mucosa will not tolerate the acid, and acid will breach through the membranes and will cause damage. Second is the parietal cell hyperplasia. Why it happens is that there is G cell overstimulation. Now we all know that the function of G cell is to secrete gastrin as well as to stimulate parietal cells. So this will lead to the parietal cell hyperplasia as well. Second is the most common association is the Zollinger-Ellison syndrome. Now what is this is there are tumors of G cell. So it will also lead to the hypersecretion of the gastrin and will release the HCl as well. So there will be ulceration in the stomach, duodenum, and even jejunum. Okay, I hope it's all clear. Now the cofactors, the other factors that lead to the peptic ulcer diseases, we all know that alcoholics have a huge risk, smokers, COPD. One thing you must know is that renal failure, that in the patients of renal failure and hyperparathyroidism, there also can occur peptic ulcer disease. Now what is the association is that in both these diseases there is calcium intake. The calcium increases, serum calcium level increases. That is a very stimulating factor. Now in hyperparathyroidism there is calcium increase, so there will be it will stimulate gastrin release, and gastrin will cause the HCl release. So it is a very harmful factor. Okay, now come to the morphology, how that is actually how a peptic ulcer will look like. Okay, now grossly it is actually a solitary, separate, shallow, depends upon the depth. 0.3 centimeter is actually the I guess millimeter. You may consider it from the Robbins. It is a hallmark. It may be shallow or deeper, and is actually a round to oval in shape, and is sharp, and that is a very important clinical feature. It is sharply punched out defect. I will show you from the Robbins as well. This is a picture of peptic ulcer disease. There is you can all see that there is a sharply punched out defect, and the base of this ulcer is very smooth, is always smooth, clean, and this base is clean because of there is digestion of the exudate. Now come to the histology. In histology there is rich granulation, vascular tissue is seen. This is all from the median Robbins, so it will be easy for you to guys to read it from that. Now what are the features how a patient will present in peptic ulcer disease? There will be hematemesis, which is vomit, blood containing vomit, and there will be sharp epigastric pain. Many patients complain of epigastric pain, so your first probable diagnosis you should ask you should be knowing is peptic ulcer disease. There will be nausea, weight loss that are, and the associated features as well. I will make a separate video on these symptoms. You can what questions you will be asking from a patient, so it will be easy for you. Okay, now coming to the next topic. Okay, the next point is diagnosis. How will you diagnose a patient? Patient comes with the following complaints, and now what you will do is, number one is the endoscopy. You will take a camera inside the GIT and see what are the features or characteristic changes. Now one thing you should be knowing is that if there is a duodenal ulcer, these are never malignant. There is no chance of developing a patient developing a cancer. So the most accurate is the endoscopy. Second is the barium swallow. It gives a contrast and gives a shadow of the GIT. So, and the third one is the lab test for H. pylori. We all know that H. pylori is one of the commonest factors of peptic ulcer disease. So it will be a very important. It is very important to rule out H. pylori factor, so that treatment will be given according to the cause. Similarly, it is of non-invasive and invasive type, which means that in invasive there will be culture, biopsy, and other features. And non-invasive there will be fecal antigen or serology testing. These are included. Biopsy is the gold standard of peptic ulcer disease. Second, you have to rule out is serum gastrin level, so that you can rule out Zollinger-Ellison syndrome. Now what is the treatment? Is general treatment includes that the patient should avoid smoking, alcohol, laying down after the fatty meal, NSAIDs for a period of time, specific period of time, and afterwards when everything is healed, he can continue it. Aspirin, coffee, as aspirin is COX-1 and COX-2 inhibitor, so it will inhibit the PGs, which are a very important factor in the mucosal protection, as they increases the blood flow and are anti-inflammatory as well. So aspirin blocks that and causes the damage. So now what will be the treatment is in terms of medication is H2 blockers, ranitidine, famotidine, and all these names you have to cram it. Second is the option is the PPIs, omeprazole, esomeprazole, and other medications. For H. pylori there is triple or quadruple therapy, which means that triple therapy includes the amoxicillin, clarithromycin, omeprazole, and metronidazole. Quadruple therapy includes you can is OMBT, tetracycline, bismuth subsalicyclate, metronidazole, and omeprazole. That is a quadruple therapy. Now cytoprotection is number one is the misoprostol. That is the one of the most important medications that are given in NSAID induced peptic ulcer. Now if a patient is having a peptic ulcer disease due to NSAID, so this is a very important medication you can give, and a very important MCQ point as well. Now second one is the sucralfate, but the common side effect of these two diseases is that it causes the GIT upset. Okay, now the last option is the surgery. That is if there is any complication of peptic ulcer disease, so we have to do a surgical intervention. Now one of the most important factor difference you must be knowing in peptic ulcer disease is difference between the duodenal ulcer and gastric ulcer. These are the most important I'm very sorry. These are the most important topics, difference you must be knowing to rule out the diseases. Now, number one, let's discuss duodenal ulcer. That is 4 times common peptic ulcer disease, and it is due to cause. It is caused by increase in the offensive agents. Right now, there will be no defect. Mucosal protection is there, but there are intense increase of offensive agents, and there is 90% association of H. pylori. Okay, eating patient complains that eating after if there is a pain, so eating will relieve his pain, and there is nocturnal pain. Nocturnal pain is very common. That patient when sleep is complains with the pain. And there is no malignancy association as well. Okay, now location of duodenal ulcer is most commonly 2 centimeter distal to the pylorus. It happens mostly occurs in young patients. Type 2 blood type association and acid use association. So, and it also radiates to the back. These are the features of duodenal ulcer. What are the features of gastric ulcer? Is that is a very it is less common than duodenum. Duodenal ulcer, it is caused by decrease in the defense mechanism. There is 70% association of the H. pylori bacteria, and it occurs in the lesser curvature of the stomach and occurs in aged persons, and type A blood type A association and the smoking association. This was all about peptic ulcer disease. I hope I have completed all the headings that can come under the peptic ulcer disease: its diagnosis, management, features, clinical presentation, morphology. So it is the topics. This topic is covered from Medium Robbins and Davidson, so it will be easy for you to cram it. I hope you liked my video. Please subscribe my channel and do comment if you have any query. Thank you.